I'm really excited to be here at the American Society of Hematology meeting in San Diego, and I think there were two abstracts at this meeting which are very important for hairy cell leukemia. One is being presented by Dr. Kreitman from the National Cancer Institute, and this was a study that he did at the NCI looking at treating patients with classic hairy cell leukemia that had at least one prior treatment with just a purine analog, and it was actually limited to one prior purine analog treatment, the majority of which was Cladribine, and randomizing them to receive a regimen we call Cedar, which is Cladribine with concurrent Rituximab, 8 weekly doses starting day 1, or Cladribine with a prospect of delayed Rituximab when disease is present after 6 months. So for anyone that's not following hairy cell really closely, a similar randomized study was done in the frontline setting for hairy cell and really showed that the survival without detectable leukemia was much longer with the concurrent use of Rituximab with Cladribine compared to Cladribine. You know, both the frontline study and this one are a little complicated in interpreting progression-free survival, as delayed Cladribine was given for detectable hairy cell without clinical relapse. But I do think that while progression-free survival is the same in the frontline setting, this is a benefit, especially for young, fit patients. So I was really excited to see that we're now getting results from this in patients who had previously received a purine analog. And they did look at response at several time points. Most notably to me was that at 6 months, we're looking at a higher fraction of patients, just over 90%, that had a complete remission rate compared to somewhere in the low 70s for those that did not, and CR is associated usually with a longer progression-free survival. And then really the rates of undetectable leukemia were higher in those who received the concurrent Cladribine, and it was about 63% in those who got the concurrent Rituximab Cladribine combination, the Cedar, versus 3% in those who just got Cladribine, and that's before any delayed Rituximab administration, so it's a very clean look at it. So I do think that this means in the previously treated setting we are seeing better, deeper remissions with the concurrent Rituximab. The current standard would actually be to give Cladribine or Pentostatin and then delayed Rituximab kind of at the end of that. So I wonder if this will move some of this a little bit closer, might be more convenient for patients. I look forward to looking at the full spectrum of toxicity data to see if it has more side effects. One notable takeaway too was that when they looked at late administration of Rituximab, it kind of leveled outcomes more in these previously treated patients. So I do think this means that this isn't a strategy for everybody and that you can get very good outcomes using Rituximab later after Cladribine. But it's just nice to see that we can get these deep remissions with Cedar even in previously treated patients. So adding to this is another abstract presented at this meeting in classic hairy cell leukemia that again was led by the NCI that we participated in as Ohio State by providing them patient information and samples because we have to work together in hairy cell leukemia. And this was looking at different biologic features of hairy cells, specifically BRAF mutations. So 98% or so of classic hairy cell leukemia has the BRAF V600E mutation, and understanding that has led to the investigation and really successful use of BRAF inhibitors like vemurafenib in classic hairy cell leukemia. But there's still some patients that have, an immunophenotype of classic hairy cell leukemia, and it's something that is biologically like classic hairy cell that doesn't have these BRAF V600E mutations. And I think it's important to look at what else might impact outcomes because not everybody's is universally good. So what they did is they looked and did sequencing of BRAF and found alternate BRAF mutations. So this was not only in patients without V600E, but also concomitant with BRAF V600E mutations in classic hairy cell leukemia. And what they noted in this cohort, which was of course retrospectively reviewed, is that with purine analog alone, outcomes fell short of our usual expectation for hairy cell of median time to next treatment of 7 or 8 years. And then it looked like, at least based on the experience in this cohort, that maybe combined anti-CD20 and Purine analog up front improved those outcomes substantially. So I think now with the wide availability of molecular testing and that sequencing could be done for a whole gene, that anyone seeing classic hairy cell leukemia patients that doesn't have the BRAF V600E mutation, or even that does, really should get sequencing of the whole BRAF gene to identify these people.